Max, and I'd like to thank the organisers for this opportunity. So, as Max has said, TAVI, or surgery for prosthetic valve failure, was the title of the talk to present today. So, my talk's just going to give a bit of background about biological valve implant rate of TAVI, and then the definitions that we need to be aware of for prosthetic valve dysfunction, and then specifically focusing on structural valve deterioration and treatment options for this, mainly redo aortic valve surgery and TAVI valve-in-valve procedure, a comparison of these two treatment techniques, recommendations, and a summary. So background, as we know, over the last 20 years, there's been a worldwide trend change in prosthetic valve implants, as we've heard this morning. Mechanical valves have plummeted and biological valves have exponentially taken off. This data is old. It's from 2009, showing, however, the trend change in the decade 1997 up to 2006 in America. Therefore, there's a huge proportion of patients out there with biological valves that will inevitably undergo structural valve deterioration, and treatment options for this are not entirely clear. These patients will be older than when they had their first procedure. They will inevitably have some comorbidities, some of which will be too severe to enable them to undergo redo surgery. So transcatheter valve-in-valve procedures emerged on the horizon in 2007. And this was perceived to be a less invasive option for these patients compared to redo surgery. However, it's still a debate. In Germany, 89% of all aortic prostheses recorded in 2016, and now it's increased beyond this, as we heard this morning, are biological valves. Several factors that have been attributed to this are that are we operating on patients that are older initially because rheumatic valve disease has gone down and it's degenerative aortic stenosis that we're operating on. However, this cannot be explained entirely. There is a trend to believe that biological prostheses have extended durability. Novel surgical bioprostheses, the concept that lifelong anticoagulation is bad for patients, particularly elderly, frail patients, and a commitment for the rest of their lives on warfarin is something that is turning patients off. And then the availability of these transcatheter techniques to deal with subsequent structural degeneration and financial drivers. So this paper looked at surgical AVR versus TAVI first-time implants, and all I wanted to highlight to you was the actual decline in surgical AVR that's been done in Germany. So over the years 2007 to 2013, there's a total decrease in the number of surgical AVRs that are done. The number of biological prostheses as a percentage has gone up, and as you can see, exponentially, TAVI procedures. So just breaking down that information, the paper at the bottom there from New England Journal of Medicine broke it down by age group, and just to highlight that in this category here, between what we would consider fairly youngish patients for aortic stenosis in Germany, they're no longer having operations, they're all having TAVIs. However, UK data is a bit more optimistic. So surgery for aortic valve disease still exists, and over the year, taken from the Blue Book data, decade 2006 to 2016, we are doing more first-time aortic valves. These are in higher risk patients. As seen here, the predicted mortality based on logistic Euroscore over this decade has gone up, but the actual mortality seen has gone down. So we're quite good at doing this operation. The background now on the durability of these procedures. So these are for AVR. There's a number of papers out there. These have just been picked up, and as you can see, the number of patients is significant, and the duration that we're looking at here is out to 20 years. Just highlighting the topic of this talk, structural valve deterioration. So freedom from structural valve deterioration out at 20 years, a mean of 60%, 80%, 95% at 15 years. So this is good data for structural valve deterioration out to long time, big patient numbers. Just highlighting two papers, however, not all bioprosthetic valves are the same. Bourguignon's paper, as we all know, looked at a large group of patients 20 years out for Carpentier-Edwards Paramount Magnaries now, but originally started with Paramount valves. And this has highlighted that essentially for the whole cohort, 19.7 years was the valve durability. Senage's group looked at the mitral prosthesis, and the highlighted incidence here was that small prostheses had a bad outcome with a high mortality rate at 5 years reported. TAVI in the UK. It's quite a scary graph, but essentially this is taken from the NICOR British Cardiac Society data set from 2007 to 17. It is exponential. There's no two ways about it. They're also changing the way they're doing TAVI in that time period. GA case or non-GA cases making up a tiny proportion, now making up 80% of cases. So they can do 4 or 5 TAVI cases in a day, 3 lists a week. The numbers stack. Here for complications, these are absolute. There's no risk adjustment in TAVI. TAVI is absolute. It's black or white. Essentially, their stroke rate still significantly higher than following surgery, and the hospital mortality has come down, but it's nowhere near the hospital mortality of a post-surgical AVR. Just looking now at TAVI procedures that have been documented in the data set there, just for the last 5 years, we've got an increase. It's not exponential, but there's a notable increased trend on TAVI valve-in-valve procedures in the UK. What's the durability on TAVI? Well, TAVI, the data's not there to the same degree. We're looking at 5-year data, and just to say that these valves, which are supposed to be, the be-all and end-all, do degenerate as well, and that's been shown at 5 years. Definition of what we're looking at, though, in structural valve deterioration, it is the valve prosthesis itself deteriorating, not non-structural deterioration, which means patient prosthetic mismatch, paravalvular leak, thrombosis or endocarditis. And it's important to know this definition because you've got to be comparing like with like, and you've got to scrutinise the papers with regards to what they are actually looking at when they're talking about operations for these patients or TAVI valve-in-valve, because quite frankly there isn't an option. TAVI valve-in-valve doesn't work for any of these 3. So we've still got to do redo aortic valve. This is, however, what we're talking about. This is the problem that is competing between TAVI valve-in-valve versus redo aortic surgery. There is actually a breakdown of type of structural valve based on the hemodynamics that it causes. So regurgitant degeneration tends to occur because of flail or wear and tear in the cusps, and these tend to occur in the bigger valve prosthesis. Stenosis type in the smaller valve prosthesis, and we heard this morning about pressure gradients being a key. In fact, this is the definition, and this has been published in the paper in 2017. Redo AVR mortality. You can read that slide, but essentially these 2 papers just highlight that the redo AVR rate 30-day mortality 2.5, 5-year survival of 83%. There are risks, though, and these are the patients that we have to be a bit worried about with regards to operative risks, but it's not unsurmountable. Morbidity should be considered, and the thing about these patients is that they require additional preoperative workup. We need to talk to them about bleeding risk. We need to talk to them about postoperative pacemaker risk. But essentially, we've done that all the way through our surgical careers. However, TAVI valve-in-valve, is there data out there? Well, we have got some data, 1-year data. Mortality rate, 7.6. Remember what it was, 2.5. And 16.8 at 1 year. And they have large gradients following their TAVI valve-in-valve, particularly in the smaller prostheses. So small caliber prostheses, if they've had to use a transapical approach, and if they have a high STS score, these are bad patients for TAVI valve-in-valve. Again, registry data. This is all registry data, only out to 1 year, and the same thing, high gradients, increased mortality at 1 year. So worse for smaller valve-in-valve, number of papers again, Egbrecht and Piberos, both basically showing that a significant increase in mortality rate at 30 days and 1.8 if you've got smaller intrinsic valves. Just to say, is this the right thing to do for patients? Is the Russian doll system, once you've put 1 TAVI valve-in-valve, are you going to do another TAVI valve-in-valve? How long do these valves survive in the position that they weren't actually designed for when the manufacturer first created these valves? And should we be thinking that a pressure-overloaded, hypertrophied left ventricle doesn't necessarily show a drop in ejection fraction, but will result in heart failure if you put in a valve that doesn't drop their gradient after the procedure? So therefore, should these patients with small aortic dimensions automatically just have redo aortic valve? A comparison. Is there a comparison? Is there evidence? As we heard this morning, there are some papers out there. 3 of them are retrospective evidence. 1 is a meta-analysis looking at 5 observational studies. So that's not hard and fast evidence by any stretch of the imagination. The conclusion of this meta-analysis here was basically that there was no statistical significance, and there wasn't an inferiority with regards to doing redo aortic valve surgery. Well, we know that. What we should be questioning was whether we should be doing this in the first place, the Tavi valve-in-valve. However, let's look at it from a guidelines basis. There is no real guidelines for this. The guidelines are for first-time implants. In the most recent European and American guidelines, we're looking at this shift again to lower ages being a cut-off for when you put in a biological valve, 50 years considered for American guidelines. So recommendations. It's got to be a heart team approach. I've been a bit flippant about Tavi valve-in-valve. It does have a place. However, the team has to be educated, and it needs to be a facilitated decision-making that's shared. And therefore, patients will be selected appropriately, and there'll be an improved referring process for treatment of these complicated patients. We have to think about the choice of treatments, and the teams that making those decisions have to be expert at offering both interventions. And we have to therefore caution a department that is really focused on Tavi, because there intrinsically will be a drive to perform more and more Tavi valve-in-valve in potentially lower intermediate risk patients. So who makes up the heart team? We've seen this before. This has been nicely covered by an article that I'd recommend you to read. It's a review article. In essence, multiple people in the room, and what we lack potentially is the anaesthetist and the overseer to govern whether these patients really are suitable to have an intervention, because they don't all need to have an intervention. Recommendation 2, we've got to think of these 2 strategies as complementary, not competing. And there will be an algorithm that's been suggested that could be applied to them. And basically, type of prosthesis failure, as I've mentioned, is important to consider to really work out what has happened to the valve, the age and their comorbidities, in particularly LV function and New York Heart Association 3 and 4, COPD and acute renal problems, operative risk and anatomical features that are preventative for Tavi, and also anticipated risks of each alternative. And patient choice has got to come into that, and the heart team has to provide this informed consent, talking about the lack of long-term follow-up after this procedure. So this is the algorithm that was proposed in that paper. Essentially, define your valve degeneration. If it is severe structural valve deterioration, look at the risks with the heart team. Look at the patient's choice, what the problems are. If your patient's young, if there's intrinsically a small aortic prosthesis in there at the time, less than 21 millimeters, then we should think about operation, unless there is significant operative risk, and then they're in this category where there has to be a conflab. And elderly patients with contraindications, such as a permeable, meaning I guess that's a lemur crossing the midline, hostile thorax or porcelain aorta, these are then shifted towards Tavi. Recommendation 3, thorough workup has to be there for these patients. CT is key. You've got to go through all of this. Then you've got to think about, particularly for the Tavi, the prosthesis type that's originally in there. It doesn't really matter for surgery because we're going to take it out, but for Tavi, valve-in-valve, it does make a difference. And this app that I'm sure you're all aware of, Vinny Bapat has created, it's very user-friendly. Cardiologists can plug in and anything, and basically it will spit out all the different type of biological prosthesis, what they look like, because not everybody knows what they look like, and what they look like when they're in the cath lab. So this is a valve that appears in Leeds a lot. It's a Radiolucent valve. It was made. It's not made anymore. The Aspire, the Vascutech company up in Leeds used to make this valve, but there are some more Tavi valve-in-valve friendly options there. So, special anatomical considerations for Tavi valve-in-valve. As I said, smaller aortic valve, they should probably have redo surgery because of this idea of putting in a small prosthesis. However, Cardiologists, bless them, fracture the stent, pre-dilate with a non-compliant balloon, then we can put in a bigger valve in valve, or seat the valve higher up in a supraannular position, i.e. pushing the boundaries. Risk of coronary obstruction, so there's that CT scanning, as I say, to plan where your coronaries are in relation to the valve prosthesis. If it's going to be high, redo surgery. No. Look, Tavi valve-in-valve surgery strategy, put a guide wire in to enable quick stent deployment. Balloon valvuloplasty to see then coronary injection. Will the valve leaflets obstruct the coronary? Let's even try chimney stenting. Put a stent into the coronary, undeployed, so you can quickly deploy it if they get obstructed. Or this, the basilica. The basilica, is this a step too far? First in man, 2017, now 100 cases in the following 18 months. Basically, electrocautery to rip open the existing prosthesis to enable implantation. However, recommendation 7, don't forget your patient is the reason why you're there, and that's part of the decision making. Is it ethically right to keep saying to patients, you can have this biological valve, it will avoid all horrible things to do with warfarin, and look, we've got a valve that can open to enable the Tavi valve-in-valve. Imagine he's 30. How long's that valve going to last? 40? Maybe a Tavi valve-in-valve at 40? Maybe another Tavi valve-in-valve at 45? 52? Boomerang effect, Russian doll, whatever you want to call it. We've got to question that we have to inform our patients fully. Redo AVR should still be the default and is preferable, particularly in this group. However, there is this out there, and it is an excellent alternative in high-risk patients. Rationale for the default is, as I've said, superior hemodynamics with redo surgery. Mortality rates are appropriate and in fact lower. And the heart team is crucial to avoid competitive approach. It's complementary. And there has to be randomized control trials before this is moved into smaller, low-risk categories of patients. Thank you.